Today's module is on lumbar facet joint injury. The facet joints are small joints in the back of the spine that help control and articulate motion of the spine. They can be injured with trauma, such as a motor vehicle crash or a fall, similar to the SI joint, which we discussed in another module. But there are some differences, and I will highlight in the history and physical examination portion of this module how to tease out a difference between these two competing diagnoses. This often causes fairly localized back pain, and if patients are not getting better with simpler treatment, such as spinal manipulation, mobilization, physical therapy, anti-inflammatories, rest, then we do diagnostic injections, and more recently in my clinic we use platelet-rich plasma to help heal this joint after trauma. This is almost kind of a companion piece to the sacroiliac joint injury. And these two structures, the SI joint and the facet joints, are often in competition as potential culprits for what's causing someone's back pain, especially after trauma. And so in my clinic, I'm often trying to tease whether one or the other joint is more involved. I've said elsewhere, women tend to have more SI joint injury and men tend to have more facet joint injury, probably because men are not as hypermobile in general. The facet joints are little flat-sided joints, and you can see them kind of here and here at each level. So here's L5S1 joint, there's the L4-5 joint. They're more medial than the sacroiliac joint, which is further out, at least in terms of when you palpate. There are no telltale signs for this on physical exam. There are some suggestive history findings. For example, generally again, in a younger patient we need to see trauma. A fall, a car crash, something serious, not a lifting injury, not lifting heavy boxes over the weekend. There tends to be less tolerance to extension. This is kind of a classic sign, and we believe that's the case because you're loading the facet joints relatively more when someone is in extension. I'll go back to the model. So we believe that when you do this, you're actually loading a facet joint more. It sounds great. It hasn't actually always been borne out in research, so I don't heavily rely on that finding. Sometimes patients will say at night they have trouble turning in bed. They'll get increased pain. I find that useful, but I don't know that it's been validated. Physical exam is pretty non-specific. I'm going to have Jennifer lie here. Some things you might find on exam, you probably find just localized pain with a straight leg raise. You might find some pain with external and internal rotation of the hip. Sometimes, if I externally rotate the hip here, they'll have pain on this side, and if this is the affected side, then when I turn them internally on this side, they get pain still to the same side that's affected. Sometimes when we do hip flexor strength testing, they'll have pain and weakness because that's going to put some stress to the lower joints there. But again, the sacroiliac joint could do that. Discogenic pain can do that. It's not very specific. The distal neurologic exam, the reflexes, etc., will be basically normal. Okay, you can sit up. I'm just going to go to the model now. So again, more of the tenderness tends to be medial towards the middle and not as much towards the PSIS, which indicates more of an SI joint injury, considering these two in the differential diagnosis. There can sometimes be tenderness of the piriformis and gluteal region. Sometimes this diagnosis can coexist with both SI joint injury and facet joint injury. Basically, it's a bit of a diagnosis of exclusion. Treatment is similar to what we do for the SI joint. Chiropractic can be helpful, or spinal manipulation, mobilization, physical therapy. They'd work on spinal stabilization as well. We do dry needling in our clinic. For patients who fail these simpler measures, what we would do in our clinic is fluoroscopically or image-guided injections. My fluoroscope is in the background. And if they responded to one or more diagnostic injections, we go forward with a lumbar facet joint PRP, which actually can be quite helpful. Steroid injections would help too, but they're only going to last a few months, and probably they're going to start to eat up the joint over time. So we tend to avoid those in our clinic. There's not really a surgery for this. Fortunately, a number of patients do not have severe pain.